Morning, everybody. Dr. Gillard here. Let's do some more spinal anatomy, shall we? It is week 8. It is spring 2020. We are in the home stretch of this quarter from COVID. Last time we talked, we just started talking about holes in the cervical spine. And we talked about the intervertebral foramen, or aka the neural foramen. We didn't talk about the vertebral foramen, so let's just go through this stuff one more time here. So there's two very important nerve protecting sets of holes that live in the cervical spine. And yeah, they protect the nerve. Nerves are delicate, right? So why not make bony holes? So the committee designed bony holes, and it works pretty darn good. We have vertebral foramen we talked about. We haven't talked about those. Those are, a vertebral foramen is the space between the vertebral, or the space between the vertebral body and the vertebral arch. Let's draw a little cervical vertebrae here. Overhead view. Pedicles. Lamina. Again, another example of why I don't draw on the board. Spinous process. Articular pillars would be in here. And yeah, so this is the vertebral foramen. This area, did I turn on my markers? I did. Vertebral foramen would be right in here. I mean, all of this. The foramen is created by the bony, and the ligaments create the foramen. And then inside the bony foramen, of course, sits the what? Thecal sac? No, we don't have a thecal sac. Yeah, there's still a thecal sac. But there's no what? There's no cauda equina here, right? That's down below L1, 2. This is a real spinal cord. We'll take a peek at it today. I'll let neuroscience deal with that more, though. Okay, and the neural foramen we talked about last time. I'm not going to try to draw the side view. Have some pictures of that. But two adjacent vertebrae, two members of the motion segment come together, and they form another hole. I will draw these nerves that let the spinal nerves exit. And remember, spinal nerves split into a dorsal rami right here, little one, and a ventral rami, right? We've talked about in that lumbar spine. We'll go over that again. But it's the same kind of deal in the cervical spine. All right, so here's an overhead view of, can anybody tell me which vertebrae this is? It's got to be a lumbar, right? No, that's ridiculous. Why is that ridiculous? Spinous process? Lumbars have spinous processes. Okay, great. Transverse foramen. That's why. Lumbars don't have transverse foramen. Do thoracics have transverse foramen? Nope. We talked about the vertebral artery a lot. Was that yesterday, I think? All right, but I can also tell, because C6 sometimes doesn't. Oh, in the bifid spinous process, we talked about that. A lot of them have a bifid, kind of a split in the spinous process, and this doesn't. This also, I can tell this is not C6, because C6 sometimes doesn't have a bifid spinous process, but this is C7 for sure, because it doesn't have, well, it kind of has it, but it's not very well developed. There's still an anterior and posterior bar. The tubercles are really, really close together on this thing, so that's definitely 7. But you can see the vertebral foramen really nicely. Don't call it the central canal or the central foramen, because we'll look at a central foramen. And the spinal cord has a hole, right, tiny hole through the center of it. That's called the central canal. All right, so this is a vertebral foramen. If I had two vertebrae stacked on top of one another, then that would be called the vertebral canal. Anytime two or more vertebral foramen come together, that makes vertebral canal. if we do a CT scan and take a mid-sagittal slice right through the cervical region, you can see this black region right here. And that is the vertebral canal. That's where the spinal cord lives. All right. Cervical neural foramen, we talked about those already. Here's that same view, a little clay blob I made for the disc. You can see all the parts, the uncinate processes. Have we talked about those? We'll talk about them a little more today. One thing I did forget to tell you about the intervertebral foramen here. I told you that they are aimed 45 degrees forward, but I didn't tell you that the transverse process has a trough, has a little groove right here. That's the groove for the exiting spinal nerve root. And this whole transverse process is actually, it's angled 45 degrees, but it's actually angled downward. You can see how they're both sloping down, and how if it wasn't angled downward, this nerve I drew would be coming straight out. Turns out it's on average about 15 degrees from the horizontal plane. That's why when we take oblique x-rays, we have to angle the tube upward 15 degrees so we can get our beam, our photons going right down that hole. All right, so we talked about that. AKA is the intervertebral foramen, or IVF. It's created by the superior and inferior vertebral notches. We talked about those. You can kind of see the inferior vertebral notches aren't very great. And it would go like down underneath here, right? The superior vertebral notch comes from the bone above or bone below. But they make up the roof and floor of the neural foramen. What is transmitted through the neural foramen, spinal nerves are transmitted, as well as arteries. There's segmental and radicular arteries and veins and things like that. And we talked about the transforaminal ligaments and the interforaminal ligaments in a previous video. And what else? The hole and name nerving, we talked about this. The hole is, you can name the hole two ways. And the hole I'm talking about would be this hole right here. So if this is 4C4 and this is C5, you can call this the C4/5 neural foramen. Or you could just call it the C4 neural foramen as well. So the hole can be named either by the vertebral notch that forms it, the vertebral notches that form it, which are the superior and inferior vertebral motion segment members, as I just said, C5 and C6. Or you could just name it for the top superior vertebrae that forms it, which would be C5 in this case. In my little case here, we use C4. Got it? The exiting nerve root is named, we said, according to the vertebrae below. So this nerve root, let's go back to this one. Let me clear this off a little bit. Get kind of messy. So this nerve root, how would you name this root coming out right here? If this was C4 and this was C5. Great, that would be C5. This is all 5. Okay, and that was the point of that slide. Right, just another example. How would you name this one? Quick, what is it? Well, it's the C5-C6 motion segment. It's the C5/6 neural foramen or intervertebral foramen, or the C5 neural foramen. And is it C5? No. C6. It always gets the name. Remember, the disc gets the name of the superior member of the, if we're talking about the C5-C6 motion segment, the disc gets the C5, but the nerve that's exiting gets the C6. Got it? I think we covered that pretty well. What nerve is this? Good, C6. Well, how can that be? It's coming out of this neural foramen, the C5 neural foramen. Well, don't forget the C6 neural foramen helps make that as well. And it takes the bottom member of the motion segment. Okay, we beat it. You guys understand that one. And yeah, this is coming on the test, right? I should have put that in the lab sheet today, but I forgot to. You got a pretty busy lab sheet today, or I guess that lab was supposed to be yesterday. This will definitely help you with lab. Just the other thing, x-rays, this is a very most excellent tool. We have cervical x-rays. We have something special we can do. Because of those holes, those intervertebral foramen are angled 45 degrees to the front, we can actually turn the patient on the bucky. And I assume you know what I'm talking about, right? Because you've all watched my YouTube video on the basics of lumbar and the basics of cervical radiography, right? Because I'm supposed to have x-ray questions. I think she's having those in the lab, PELP lab, but I usually have those on my test as well. But I explain about this bucky and how photons create a film in an image. This thing is called the bucky, and you put the patient against this white bucky, and old school, you slide a film, put a film in a cassette and slide the cassette like the old type of photographs used to be. And then you shoot photons at the patient, and they penetrate the body at different levels of success. But you can see in this patient, he's actually twisted about 45 degrees. There's a 45-degree angle right here. And so this is always super confusing, but 45-degree angle. So you would call this a right posterior oblique. The part of the body that touches the bucky is what names these twisting shots. So his posterior shoulder, his right posterior part of his shoulder is touching the bucky. And so this is a right posterior oblique, or RPO. If you don't have RPO markers, you would put the right over here. Because it's behind the spine, you know this is a posterior oblique. If it was an anterior oblique, you would put the right out here in the front. But yeah, twist them 45 degrees. You have to angle the photons up about 15 degrees. That's way more than 15 degrees. And here's the skeleton. I twisted in exactly the same position. I went about 35 degrees, I bet. Should have twisted him a little bit more, and we would have seen these holes. And I angled the camera going up about 15 degrees. I didn't do it perfect here. I need a little adjustment, but yeah, so that's the important concept about anterior obliques versus posterior obliques. For an anterior oblique, let's say a right anterior, did I put one in here? No, because I'm getting out of control. I mean, you'll learn this later on. But if you had him face the bucky and you twisted him so his right shoulder was hitting the bucky, it would be a right anterior oblique. Okay? So the other point I wanted to make, so let's go back to this one. In a right posterior oblique, which intervertebral foramen are you seeing? The right side or the left side? There's the board question, right, for radiology, x-ray placement. Well, these are the other side. These are the left. You actually see the contralateral IVF with these posterior obliques. And these are by far the most easy to do, right? Because if you do anterior obliques, the patient's face is smashed in there, and it's kind of, I mean, you're looking at their backside, and I always shot these posterior obliques in my clinic. Anyway, that's the story with those. Right? So what is this image? If you see something like this, well, you can see his jaw right here. You can see the jaw would go out like this. There's his teeth. So this way's front, right? Yeah, this way's back, posterior. So the marker is placed to the posterior. So this must be a right posterior oblique. So what IVFs are these? Aren't those beautiful? See how nice you can see those IVFs? We could see if there was a nasty bone spur. I'll show you a case of mine. I think was it this year, last year? I can't remember. But you can get bone spurs going right into these holes. I mean, the nerves are inside these holes. These are the spinal nerves coming out. So you can shish kebab. I should draw the Nerves yellow. You can shish kebab the nerve root. Get horrible pain and weakness down the affected myotome. Yeah. So what IVF, the question was, what are these, the right or the left intervertebral foramen? Well, let's see. This is a right posterior oblique. That shows the side opposite neuroforamen. That shows the left neuroforamen. So these would be the left neuroforamen. Got it? So if I ask you a simple question, maybe an extra credit question, maybe a real question, make sure you know that. All right, now let's kind of take a little, none of the rabbit, I guess it's kind of the lecture of the rabbit holes. We're going into another rabbit hole. So just some basic, and we covered a little bit of this, I think, somewhere. Or maybe that, yeah, at the beginning, but let's get through this. So central nervous system, there's a peripheral nervous system, an autonomic nervous, well, it depends how you break it down. But I mean, I think of it, there's a central nervous system, a peripheral nervous system, and an autonomic nervous system, which is, well, I won't go there. I'll just leave it like that. The central nervous system is made up of the brain. Here's a brain up here, which you'll study in neuroscience, and a spinal cord, which is right here. So the spinal cord is a kind of a tubular, or it's solid. It's like a rope, but not like a rough rope. It's like a smooth nylon rope. It has some enlargements here, the cervical enlargement. There's a lumbar enlargement here, because these are very busy areas which form the brachial plexus and the lumbosacral plexus down here. That's all I wanted to say about that. Of course, the brain is your control tower. You think about things. You want to wiggle your toes, you send a command down. It goes into probably the toe muscles. Those are probably be S1, L5. So it goes way down here, goes out, goes down to your toes, and you wiggle. Or if a dog bites your toes, the sensation of pain goes the opposite direction. So we have messages going up and down this spinal cord all the time, with your brain processing this information and telling you what to do, if anything, on all this information. So that's basically the CNS. Spinal cord, again, it has actually 31 levels. So the solid cord that looks like a rope is really chopped up into pieces of big, thick pieces of salami, which you can't see, but they're there. And these are called cord levels, and there's 31 of them. Why this comes up, I don't know. But there's 31 of these things. So we have 8 in the cervical. Why 8? Why not? There's only 7 bones. How come we have 8 of those? Well, how many nerves are there? How many spinal nerves? There's 8. So these match the number of nerves. There's 12 thoracic segments or cord levels. There's 5 lumbar cord levels, 5 sacral cord levels. Now wait a minute, the coccyx has 4 segments. How come there's only 1 coccygeal segment? Way down here. This coccygeal segment, about the level of T12-ish, I would say. Oh no, that's even further. That's at the level of about L2-ish. That's the tip of the conus medullaris. Well, there's only 1 coccygeal nerve. Where's the other 3? They're actually part of they think they're part of the phylum terminale, is what the histologists tell us. They're kind of remnants of these CX2, 3, and 4 are remnants of the phylum terminale. Right? Each segment will give rise to a motor and sensory nerve root. A little bit different design than we've seen before. They don't just all of a sudden, nerve roots don't appear. They're made by maybe 5 to 10 little rootlets, and those form into the sensory motor. I'll show you pictures. You'll understand more about what I'm talking about when we look at the picture. And the motor and sensory nerve roots, I think I've talked about this before, but they combine usually within the neural foramen or the intervertebral foramen to form one single nerve. And that's a mixed nerve, and we call that the spinal nerve. Did I not say that? Oh yeah, a mixed spinal nerve. That's kind of, let me make a note of that. Maybe you can make that a little, clean that up. When the nerve roots leave the spinal cord, they take the dura mater with them. Remember, these nerve roots at each level, they have to go through the intervertebral foramen to go out to do their jobs. They actually take some of the covering of the spinal cord, which is called dura mater and arachnoid mater. They take that with them. Those are called nerve root sleeves. Nerve root sleeves are, anecdotally, we don't have any studies on this, but I've worked for several spine surgeons, pick their brains thoroughly, and anecdotally, a disc herniation or a bone spur in the nerve root, especially the axilla of the nerve root sleeve, especially of the axilla of the nerve root sleeve, is very delicate. So you can get some really horrible pain symptoms with compression on there. But here's the cervical spine. This is a really nice image. We can see those, some of the anterior spinal artery here that we talked about last time. But that's not the point of this. So here's the spinal cord, the cervical spinal cord. In fact, we got a C6, C5 root level, C6, and a C7 root, or cord level. These are the cord levels. But look at all the rootlets. So we've been working with these. Here's a solid root right here. Motor roots are anterior. Sensory roots are posterior. So this would be the sensory root of C5. This would be the motor root of C5. But see how when they dig into the cord, they don't go straight in. They go at numerous levels, 10, maybe 15. They're variable. But these little guys can't call them nerve roots. They're called nerve rootlets. Nerve rootlets. These are the motor nerve rootlets. These are the sensory nerve rootlets. Okay, are we good with that? And notice that these nerve roots, remember the lumbar spine, they'd come out of the cord level up at T12 and they'd have to go all the way down. These come out up in the cervical spine and almost go directly out. They start to drop a little bit further you go down, but they're pretty much, the neural foramen is pretty much at the root, at the spinal cord level. All right, and then in the intervertebral foramen would be about here, right? And there's a dorsal root ganglia where the cell bodies are. I haven't done my little neurology lecture, but we'll get to that. But remember, these nerve roots combine to form a mixed nerve, just one nerve, very busy nerve. It's got sympathetics in there, it's got sensory, it's got motor, and that's the spinal nerve, right? Those are the little yellow things you see on those little plastic models. It doesn't live very long, right? It's going to split into pieces. But that's kind of the story there. Okay, we also have, let's go over this. This is the spinal cord itself. We don't have this in the lumbar spine. It's the first time we've seen this. So you'll learn all about this. Every nook and cranny of this thing you'll learn. For me, I just want you to know 3 parts for right now. We have white matter on the outside, white matter. On the inside, we have gray matter. Okay, this myelinated, these are tracts out here that are myelinated, that's why it's that color. And there's a little bitty hole right there, there's your central canal. You have cerebrospinal fluid around the outside of this, but you also have cerebrospinal fluid going right through that little central canal there. Okay, are we good with that? Then, as I was talking about, so this is the dural sac, or the thecal sac, just like we saw in the lumbar spine. But we didn't see this before. It's there in the lumbar spine as well, but it's much higher. When the nerve root has to come out and go through the IVF to do its job, it stretches and takes the dura mater with it. So these are called nerve root sleeves. So this is a nerve root sleeve. It still has dura, arachnoid, and the nerve roots have pia mater around it, so it has the 3 meningeal layers. But once it gets out past the dorsal root ganglia and becomes a spinal nerve, These morph into the perineurium, epineurium, and the regular peripheral nerve covers that you know. You'll learn that more in neuroscience, though. All right, that's just, we've covered all this. That's just a kind of a blow-up of everything we've done there. I think we got that down. Here's a cadaver view of it. See 6 vertebral bodies right here. And here's the lamina in the back. Spinous process would be back here. Okay, so it's a axial cut right through the vertebral body level. And you can see the spinal cord, right? We can see the nice white mater. We can see the gray mater right here. Looks like an H. Central canal would be right there. And then we can see the nerve roots. Can't see the nerve rootlets. They're kind of smushed together. There's some below that you can't see, but that would be the C6 ventral root. There's the C6 dorsal or sensory root. And then it gets into all this mess. Dorsal root ganglia would be right in here. Probably kind of all blends together. You can see the transverse foramen for the vertebral arteries quite nicely. There's the, if this is C6, there's the superior articular process of C7. There's the articular cartilage. There's the facets of the superior articular process. There's the facet of the inferior articular process. This is the zygapophyseal joint, right? That's what we do. We adjust these joints. So that's pretty cool. What else can we see? Lamina is here. Ligamentum flavum is here. Dura would be here. Arachnoid mater would be thinner. They're so thick, stuck together, you can't really see which is which. This, what's this space? I have one on the lab notes. What's all this space, would you call this? If you're inside the dura and arachnoid mater. This is pia mater wrapping around the spinal cord. So this is the subarachnoid space. Subarachnoid space. We can see all of this stuff. Everything underneath here. This is all subarachnoid space. Okay. This is a picture in your lab. It's a very busy picture. You got a lot of work to do. There's 25 of these things. So this is your lab work for today. Or actually for what day? It's really Tuesday today. But you'll be reviewing this tomorrow. So this will help you. These are the answers. I'm a little off track with my labs, as you can see, as usual. Yep. So let's go through this stuff. So we just covered all this, but let's start with this back here. Transverse process. Actually, let me get my little drawing tools out. So number 9, this bone right here, that's the lamina. So here's a pad. Let's do 5 first. That's this process of bone. That's the superior articular process. And then the little pad on the top, that's the facet of the superior articular process. Right? This is the C5 vertebral body. Call that the bony implate. I don't know. It looks like maybe some cartilages there. You could maybe, that's part of the cartilaginous implate as well. Couldn't really take either answer for that. We went through the number 1, that's the white mater. Number 2 is the gray mater. Number 3 is the central canal. How about number 8 right there? See it peter out? It's ligamentum flavum. Is that it? Yes, that's ligamentum flavum. This is a epidural venous plexus. You can see there's an anterior epidural venous plexus here, number 7. Okay, there's, how about number 11? No, it's not roots. Those are rootlets. Are they ventral? Are they motor or sensory? Well, motor is anterior, so these are the motor rootlets. Motor rootlets. Of which nerve? C5. This is C5. What disc? What if there's a disc here? What if there was a disc? What disc would that be? C5? No, it'd be C4, right? Because the bone on top has been removed. The bone on top names the disc. So these are C5. All this nerve stuff is C5 here. What else we got? We got, is that a rootlet still, number 12? What is that? That's sensory. That's a sensory root. And it gets big and fat here. What's number 13? That's the dorsal root ganglia, which contains the cell bodies of the sensory root. What's 14? Motor root. I think we did that. How about 18? Be about from here to here only. Good. That's the spinal nerve. Very short-lived. Splits into 2 pieces. Good. We already kind of talked about that. There's a dorsal ramus, this one. Medial branch. Remember that sends fibers, nociceptive fibers, into the Z joint. That's where the source of pain goes down the medial branch. And from the level above, right? C4 coming from above also plugs into this. There's the lateral branch. Sometimes there's an intermediate branch. Sometimes there's not. How about 22? Good. That's ventral rami. That was dorsal. Did I say ventral? That's dorsal rami. Posterior rami, anterior rami. Well, let's do this first. Number 24. You've seen these in anatomy. Well, maybe you haven't seen this yet. You probably have already. That's the cervical chain, sympathetic chain, cervical sympathetic chain. There's cervical, there's a upper, middle, and a thoracocervical ganglia, sympathetic ganglia. But this is just the skinny chain here. This is the gray ramus communicans, number 23. That's easy, better not miss that. More specific. Vertebral artery, but which division from yesterday's lecture? No, it's not V2. It's V3. No, it's not V3. It's V2. It is V2. V3 is born when it leaves the superior part of the transverse frame of C2. Did we get them all? I think we got them all. 25, of course. It's the anterior strut of the transverse process of C5. All right, so work on that. That's an important deal there. Oh, I guess we could have blown it up, made it a little easier. I can't, with this Camtasia thing, I can't see the slides. I can't put it in the mode where I see the slides coming. I usually see one slide ahead so I can see what's coming. Whew. There's only 2 pictures in lab today, and this is one of them, but it's a busy picture. There's another one I could throw on the test. I like this one because it shows the disc in here. There's the C5 vertebrae. Is that right? That's an error, isn't it? If that's C5, that should be the C4 disc. Bad. I'm surprised I didn't catch that last quarter. So let's fix, I don't even know what slide this is. 98. Fix error. All right. You can see these medium-sized arteries. You've seen that in the body already, right? How for example, the posterior tibial artery, how it travels with 2 satellite veins. Medium-sized arteries love to travel with satellites. And so here's 3 satellite veins. These are vertebral veins. That they never get shown. We don't talk about those. But you could get blood clots in those possibly, but usually they don't cause too much trouble. So I think we covered everything on that already, so nothing new. Vertebral arch, kind of talked about what makes the vertebral arch. So we have a pedicle region would be right here. This is pedicle. This region here would be articular pillar, lamina, Some authors say spinous, some don't. Some say the lamina fuses together here. Some say the root of the spinous process is here. So I'd stay, if I was writing questions for that, I would definitely stay board questions. I would stay away from that. Or at least not have that answer choice. And then the other sides. What was this called? Vertebral canal? Really, technically the vertebral foramen. And notice how these are angled 45 degrees, right? From a horizontal. It's like a horizontal. Okay. The other concept is I talk about the roof a lot. Oh, the roof of the vertebral canal. The roof is really lamina for the most part. I mean, if you want to call it root of the spinous process, if you're in that camp, you could call it. I usually just call it the roof is the lamina. The floor is the vertebral body and the disc that we don't see. That makes up the floor of the vertebral canal or vertebral foramen if you're talking about one level. It's kind of an important concept. Okay, let's talk about the cervical disc. This is going to be really easy because we already talked about the lumbar disc, and really it's just the same. Cervical disc is actually a little bit tougher than the lumbar disc. Herniations, they happen a lot there, but they're a little bit more rare than the lumbar spine. There's two parts. There's a nucleus pulposus, annulus fibrosus. There is an end plate. There's a vertebral end plate as well. And same deal as before. They're designed like a steel-belted radial tire with a annulus fibrosus along the outside, corralling the nucleus, the watery nucleus pulposus. Remember, the nucleus pulposus is about 80% water. And it's corralled. The nucleus pulposus is made up of type 1, belts of type 1 collagen. That's an error. I have to fix that one too. Type 1 collagen. Type 2 collagen is in the nucleus more. Type 1 is very strong. That's like steel-belted radial. That makes up the lamellae of the annulus fibrosus. It's a little thicker anterior, which helps the vertical diameter or vertical dimensions are a little bit higher, so kind of causes a little bit of wedging and helps form the lordosis of the cervical curve. I don't think we go too far. We don't have to worry about that. Here's that same picture. Remember how the lamellae, the belts, the type 1 collagen running in these things is 65 degrees from a vertical. If I dropped a vertical line down and I measured the direction of these type 1 collagen fibers, it would be 65 degrees on average. But that's this fiber. That's this band, this lamellae. The adjacent lamellae are running negative 65 degrees. They're running the opposite way. You see that? The committee did great with that. But remember, the committee had some problems. The same deal. The posterior lateral superior corners, there's weakness. These lamellae don't go. I didn't write that again because we already talked about that in the lumbar spine. But that applies everywhere throughout the spine. Cervical disc herniations, you're going to get a lot of information on that, but the most common cause. You have a patient coming in your office, he's got maybe a little pain in his neck, maybe he doesn't have any pain in his neck, but he's got horrible burning, stinging, lightning sometimes. Everybody's different. Some people, the pain will run from his trap through his arm, through his forearm into the hand. Some people it'll just show up in the hand. Some people just in the forearm. Some people just in the arm. But it won't be the whole arm. It'll be just one region of skin. When that happens, that's called radicular pain. All right, one of the most common causes of that type of pain is a cervical disc herniation. There's also, you can have bone spurs, you can have joints of von Luschka spurring, uncinate process spurring. We'll look at a case in a little bit on that. But by far the most common thing you should suspect is a cervical disc herniation. Can chiropractors treat disc herniations? Wow, those are fighting words at our college and our profession. My opinion is make sure you use flexion distraction treatment. We have traction type treatments for those things. Some believe in adjusting, and so I won't get into that road. I get people very upset with me when I talk about that. But I'm not of the camp of adjusting, cracking the neck in someone who has a rip in their disc that's caused a herniation. But anyway, you'll form your own opinion as you go through the school on that. But we can, one way or other, we can definitely treat them. We can treat them with traction, in my opinion. But anyway, so they don't always have cervical spine pain. It may be just this radicular pain in their arm. They may have had an injury where they hit their head on something, an axial load injury. Maybe they're a driver, UPS driver, and they're constantly twisting or turning the neck. That can wear out the disc. If their parents, grandparents, immediate parents, if they have a history of a spine surgery, they have a much greater chance of having a herniation as well. And the disc herniations, to see them, you can't see them on x-ray. You can't even see them very good. You can get an idea of what they look like on CT. But a magnetic resonance imaging is by far the most important test. You will be ordering a lot of these tests once you get out of here and get your license, because that's the only way you can see if they have a herniated disc or not. 40-year-old female comes into the clinic, some stiffness in the cervical spine, but her main complaint is a radiating pain from her trap down her arm, the outside of her arm, the outside of her forearm, into her left hand. She has a little bit of radiation. This is a true case. Has a little bit of radiation down the right upper extremity as well, which isn't as bad. Neurological exam was done. She had an absent left brachioradialis reflex. What root level is that? 6. What level is bicep reflex? 5. What level is tricep reflex? 7. That's good for about 70% of people. Everybody is neurologically mixed up a little bit. So those rules don't always work, but those are the ones we use for board testing. And yeah, those things you should know for forever. Until you retire from being a chiropractor, you have to know brachioradialis is C6, biceps C5, triceps C7, and those dermatones as well. I won't go over those right now. I think you're actually starting to learn them though. But yeah, so already, before we know anything, could you tell me if she's got a herniated disc, what level it would be? It could be a bone spur too. But what level are we worried about? Well, the C6 nerve, right, brachioradialis reflex, that's C6. If that nerve is out of action, who's the most likely suspect? C5 disc herniation, right? C5 disc herniation gets the C6 nerve root. All right. By the way, because of these positive neurological findings, she had some numbness in her left hand and left lateral forearm, musculocutaneous, or the lateral femoral cutaneous. Lateral antebrachial cutaneous nerve, which does not come off the brachial plexus like the medial antebrachial cutaneous and the medial brachial cutaneous. They come right off the brachial plexus. Where's the lateral antebrachial cutaneous nerve come from? If I was in cadaver lab, I'd show you right now. It's a extension of musculocutaneous nerve, hence musculocutaneous. So we can see that right at the bicep. It comes out and runs down the lateral forearm. Yeah, so you can make the diagnosis of radiculopathy because she probably has a radiculopathy. We haven't worked on cervical imaging, but here's a cut of her C3 level. Right? It's a T2 weighted. Now it's a little different. There's the spinal cord. There's the cerebrospinal fluid. So there's no big bump sticking out there. This is the cut line, whatever that cuts through. If this is a stick of salami and we cut the salami up into 20 pieces, I want to make my salami with this slice. We pull this out of the stack and throw it down the bread over here, and we can look at it. And this is the left side over here. Images are reversed because you're really looking from the bottom up. But now we can see the spinal cord quite nicely. You can see the white cerebrospinal fluid around it. If you look really closely, we can see, just like that cadaver picture, there's the motor root, posterior, the dorsal root. Can't really see those rootlets. Just in cartoons you see those. But there's the there's the motor root in the front. There's the dorsal root back here. It's a little bit harder to see here. So we want to look, and dorsal root ganglia would actually be hanging out in this region, which you can't see that good. These are the vertebral arteries in the transverse foramen here. So the roots would be right in here. You can't see them as good as you can in the lumbar spine, but they're in there, and they're pretty big. So bottom line, nobody's irritating that, are they? The disc looks fine. I don't see things sticking out. Now let's go look down at this level. I blocked it out. I didn't want to spoil the surprise. Oh my goodness. First thing, this is a mid-sagittal, or this is just one cut to the left of a mid-sagittal line. These lines are off a little too. Sometimes these lines aren't perfectly matched up like they're supposed to be. But you can see the spinal cord coming down. See how it gets divoted here? Really divoted there. So C5, I put a cut through that, and this is the cut through C5. And you can see a massive herniation. That's all disc herniation material. And so we can't see it, but the nerve root is just smashed. Remember that motor root was up here in the front, so that's smashed all the way back here now. So, and it's on both sides. That's why she has pain on both sides. Very big herniation for cervical spine. Not dangerous, though. There's not enough compression. This ligamentum flavum thickening is right here as well. So, yeah. Right. So patient had a moderate C5 disc herniation, which that's perfect, right? It gets the C6, left C6 exiting root. And yeah, it's not, some people can have herniations and have no pain. How come? Because there's no inflammation. The research is pretty good on that. You have to have compression and inflammation. And rarely, if you get leaking cytokines out of the disc, you can have an inflammation of the nerve without compression, and they could have a full-blown radicular pain with a normal-looking MRI. It's rare, though. So she failed all chiropractic, physical therapy, tried acupuncture, nothing worked, ended up having the Peyton Manning surgery, the anterior cervical discectomy fusion. Here's you know where you are. There's the AP view, anterior vertebral body. And, hey, how come my little marker disappeared, didn't it? There's the troughs, nerve root troughs. But, yeah, they take the disc out and they put some kind of synthetic disc in there. Or they can take a chunk of bone out of your hip is probably the best way to go, even though you might be left with a little hip pain, because that's guaranteed to fuse. I talked to tons of clients. They don't have successful fusion between here. They've called pseudoarthrosis. It's related to chronic back pain. But yeah, there's a Peyton Manning surgery, single level. Here's a client that had a double last year. Did pretty well. It's a very successful surgery, as long as it's done by skilled hands and for the right patient. The horror stories occur when, like that YouTube video I have on that poor guy from India, right, who they just destroyed. Yeah. Let's see, how are we doing on time? I think we're fine. So let's get into Luschka joints here. So those are Batman's ears. I think we talked about them a little bit already. Let me get I don't know where my marker kind of disappeared on me. Batman's ears, and here's an AP view of, looks like C5. And we can see the uncinate processes in this view quite nicely. Lots of AKs for this uncovertebral joint. Uncovertebral joint. Joints of Luschka, joints of von Luschka, uncovertebral joints of von Luschka. Lucia, that's wrong. That's got to be fixed too. I don't know why when I prep I don't see these things, but when I talk to you for real, I catch all sorts of stuff. This is Batman 111. Lucia, no, Luschka. They are found between C3. C2 and C1 don't have them. C3 can have little remnants of one. C1 can actually, or T1 can actually have a remnant as well. Could probably put that down here. They're the tallest between C4 and C5 and 6. They're made up of two components, the uncinate process, also called the uncus, and the facet. There's a facet on the inferior part of the vertebral body that accepts the uncus, and that's just called the facet for the uncinate process. Really no official name for that, which is surprising. There's a name for everything, but not that. Uncinate processes? Yes, those are not really Batman's ears, of course. Here's another view of them. You can see them right there in this, the spine, the skeleton in the anatomy closet. They're there again. What were these called right here? See that roughening? This is a young skeleton. It's not very developed. Anterior tubercles, posterior tubercles of the transverse processes. Scalenes connect there. Here's an older bone. You can see the uncinate processes are more rounded off. Yeah, you can still see those trough. This one's really coming forward. I mean, the nerve would be coming right down there, right? How is the joint classified? The uncovertebral joints, controversial to say the least. Some authors believe it is a real synovial joint, and some don't say anything. Kramer doesn't even weigh in on that. Because there is a synovial membrane, at least in part, Hartman studied this in his research paper. Standring talked about Hartman's paper, so Standring's a board book, so it is a synovial joint in regard to boards because of Standring's mentioning of it. What does it do? What do those little Batman ears do anyway? Well, they support and stabilize the cervical spine during lateral bending. When you bend to the side, the right and left, it makes it so the bones aren't going to slip out. You're not going to get a lateral listhesis because of these things. It also prevents far lateral disc herniations because you can't get a disc herniated through there. I mean, you could, but it's pretty unlikely. You could develop bone spurs because we talked about these do make up the anterior, really the anteromedial border of the vertebral canal, right? Because there's the vertebral body, spinous process. Remember the cervical spine, there's the anterior strut, posterior strut, transverse process. Uncinate processes are right here. Oops, a little big. But if you get bone spurs like this, your nerve root is running right through here. I guess I can make that orange. Nerve root is right through here, so you can shish kebab that nerve root, have horrible pain down your arm by these bone spurs coming off the Luschka joints or off the facet for the Luschka joint. So they can be a source of radicular pain. The vertebral artery, I mean, if they occur up in here, transverse foramen are right about in here. So you can get transverse foramen, the vertebral artery getting shish kebab by one of these too. It's rare, but it happens. not a good thing either. You get insufficiency. It acts as a beaver dam. You start getting decreased blood flow to that part of the spinal cord. And is that a good thing? That's not a good thing. Right, here's a better view of this. This side is normal, but you can see Lischka joint is right here, or the uncinate process of the Lischka joint. So yeah, what's going to happen if you get a bone spur anywhere here? It stabs, it shish kebabs. If you get one way lateral, it can shish kebab. A big one, it can stab the artery. It has to be really big, but some of them get huge. And that's what's going on over here with this little cartoon. Also, the Z joint, superior articular process. I mean, a bone spur coming this way can also stab the nerve root. Couldn't see this in the lumbar spine very well, but in the cervical spine with those oblique views, we can get a picture right down the chute, so to speak. We can see those on X-ray. Right, and that's just kind of a blow-up of that. These supraarticular process bone spurs crushing the dorsal root ganglia here. We got some coming off the uncinate process as well. You can even have them coming off that facet region, as we'll see. Okay, we kind of talked about this, what nerve root is being compressed by this herniation. So this is a C6 disc. That's a C5 vertebrae sitting on top of the disc, because the bone, the C5 bone would be taken away to see this picture. Or no, let's see. This is a C6 disc. So the C6 vertebrae has been taken away. So this is C7 property below here. So that's the C7 nerve root. And there's a picture of a herniation. The annulus fibrosus is ripped right through, and the nuclear material is pushing out right into that, those motor roots, causing a lot of pain. Ligamentum flavum, we talked about stenosis. That's getting a little too advanced, but you can get something called myelopathy because the tracks for proprioception are right back in here in the spinal cord. And ligamentum flavum gets thick like this, like it does in a lot of people. It can smash into this, kind of pinch the spinal cord, and they think they have MS because they get upper motor neuron symptoms of that. Here's a 30-year-old male. He came in with bicep weakness and burning in the lateral arm on the right. Should add right to slide 130. I got a lot of work to do today. On the right, MRI was performed. What do you see? This MRI, sometimes the quality's not the greatest up here. Oh, we can see to get yourself orientated, we can see I don't like that color. Let's go orange. What's that? Oh, he's got hypoplastic artery too, doesn't he? Yeah, it's like the circle of Willis. I didn't get that deep into the circle of Willis, but only one side of it is dominant. Just like your coronary artery system in your heart. You have a right coronary system or a left coronary system. Same thing, you can have a right-sided dominant vertebral artery system, hypoplastic. These people are at risk for stroke too. Don't want to go too far in the rabbit hole. But yeah, here's a big herniated disc right there. Right? On this side you can kind of see the nerve root coming out right there. That little darker gray. Dorsal root ganglia looks a little further out than normal. And here where is it? I mean, it's all smashed up in here. So that would cause let's see, if this is C5 disc, it would cause C6 symptoms. So this case didn't match, which sometimes happens, but it shouldn't be more than one level off. Like it might, C6 nerve root injury could present with C5 symptoms or C7 symptoms. Everything we said. Oh, it's another case. 58-year-old male comes in. I remember this guy. Severe radicular pain in the right arm. Hang on, let me make a note of something here. Matching. severe radicular pain on the right arm, weakness on the right wrist extensors, brachioradialis reflex is gone. Which one is that then? You're thinking C6 problem. Yeah, absent. The one on the left is fine. Sensory testing feels hypoesthesia. What's that mean? He can't feel if you run your fingers over his skin, or if you run a pinwheel or a broken, however you do it. If you run a broken, I think they're changing the clinic to break Q-tips, wooden Q-tips in half, and just kind of run that over. Our spine surgeon just uses fingers. I mean, touch is pretty much touch, I think. But that's hypoesthesia. You can't feel it. It's like, are you touching me? It feels funny when you're touching. That could be paresthesia too. But you ordered a CT. The x-rays didn't show anything. Here's a CT. Okay, so let's check it out. Let's look at C4 here. Oh, look, Batman's ear is really nice, yeah? Oh, beautiful Batman ear. What are those called? Uncinate processes. Now, some of you already see the problem. So the problem, he had right radicular pain. And yeah, we see, where's the uncinate processes? Here it is over here on the left side, but this one's destroyed. It's blunted and it's actually sticking straight out. And same with that facet for the uncinate process. That's all wicked bone spurs. So not good. He needs surgery, but he won't do it. Can't remember why. He's on opioids. That's probably why. All right, everything I said there. All right, special bones. Let's go a little bit more. Atlas and axis. It's a really nice image with my camera, which I'm actually sending back. I've been playing around with my photography. That looks pretty good, though, from here. But this is an A to P view of the top two bones. This is atlas right here, and this is axis underneath. Axis is weird because it's got this weird bony peg that sticks up called the odontoid process, which you can see it's hiding behind the anterior arch there. But that's when you rotate your head, you rotate around this peg right here. So pretty cool design. But let's talk about them. Atlas first. So it's one of the two atypical cervical vertebrae. The other one is the atlas. So these are obviously weird looking, so they're atypical. It is the widest of all cervical vertebrae except for C7. It's the very top. It got the name Atlas because Atlas holds up the world. And so there's the skull. Atlas holds up the skull. It's very weird. Here's an overhead view of it. Very weird. This is actually a S to I view. I can tell because here's the facets on the bottom, inferior articular. Facets of the inferior articular process are flat. So this is a I to S view. Nevertheless, where's the vertebral body? Right? It should have a vertebral body right here. Where is it? Doesn't have it. Got stolen embryologically by that C2. But it does have some parts that we can talk about. So it's got an anterior arch. That's different, isn't it? Off the anterior arch, there's an anterior tubercle, which is not an AKA for the anterior arch. There's a posterior arch. Oops. It's hot today. My fingers are getting sticky on this little slide trackpad. There's a posterior arch. There's a posterior tubercle that comes off this. Can't see it too good on this guy. That's a posterior arch. And then it has these lateral masses, they're called. They're really just the articular process, or the superior. They're the articular pillars, really. But you don't ever call them articular pillars. You call them lateral masses. Right, so those are the parts of atlas. Here's an overhead view. See how scooped looking these are? These are more concave. Those are the facets of the superior articular process. And we'll talk about all these parts as we go through this. But same, anterior arch is here, anterior tubercle, and there's a facet for the superior articular process, off the lateral mass, colliculus atlantis right there. We'll talk about that when the time comes. There's the posterior arch, this whole thing here. There's the posterior tubercle, you can see better right there. Transverse process, they're not really double strutted. I mean, sometimes they have little double struts like this. See, but they're very anomalous looking. One side can be quite different. When you try to palpate these in lab, probably maybe one student out of the class will have one that you can actually feel for real. But a lot of times you'll only feel it on one side because they're quite variable. Right, there's all the pieces that you need to know. We'll hit some more of these. Or I guess I'll hit them now. So this is the joint. Remember we talked about the occipital condyles? Well, this is part of the occipital condyle joint. When you're naming joints, you always, out of respect, you always name the atlas first. And the atlas is given the name atlanto. So the joint between atlas and occiput is the atlanto-occipital joint. Okay, so that's half of the atlanto-occipital joint. Transverse process. Groove for the vertebral artery. We'll talk about that in depth, but the vertebral artery runs. Sometimes there's a ligament over the top that calcifies, makes a little tunnel for it that runs underneath here. And on this side, you can actually see it. So that was the posterior atlanto-occipital membrane, a piece of that calcified. And it caused a new tunnel called the arcuate foramen. Posterior tubercle, we covered all that. Colliculus atlantis is a very strong ligament that runs here called the transverse ligament of atlas. That is very important for good stability because remember your spinal cord is hanging out in here. Very delicate. You don't want to... You want the C1 and C2 to be anchored together. The dens would be right here, and that's what holds this whole C1, C2 complex together, this transverse ligament of atlas, and it anchors into these colliculus atlanti. Singular is colliculus atlantis. Right, I think everything else you pretty much know. That when that posterior atlanto-occipital membrane calcifies, that's called the posterior ponticle. We actually have one of those in class that you can see. Or I guess you guys can't see, but take my word for it. You can come in second quarter, feel free to come in to see the posterior ponticle. Just the pieces again. There's the posterior arch, superior articular process, facet of superior articular process. Well, we're not going to call this the articular pillar, but technically it is. But we're going to call it the lateral mass, anterior tubercle. You pretty much know the deal there. We said this, lateral masses are just really articular pillars, but we don't call them that. We never call them that. Lateral mass is made up of a superior articular process and an inferior articular process. And it's capped with, which you can't see, but we can add it right now. There's a pad of hyaline cartilage, very strong articular cartilage, caps all joints is here. We call it the facet of the superior articular process. I guess you could call it facet of the lateral mass, but it's better than to call it the facet of the superior articular process. There is a pars. Usually don't get fractures through the pars, though. I mean, it could happen. Fractures are more common, these Jefferson fractures, where football player drives his head into some 350-pound lineman, and axial load injury shatters this ring of bone, so you can get a Jefferson fracture. You could get lateral mass fractures, but it's not through the pars. It's usually more like that. You can get an avulsion fracture at the colliculus atlantis as well. I won't test you on those things. You will be learning those, though. Its articulations, we already said, the superior articular process of atlas connects with the occipital condyles to give us the atlanto-occipital joint. True diarthrodial joint has a full capsule filled with synovial fluid, just like a Z joint. The inferior articular process of atlas connects with the superior articular process of axis, and that makes the, out of respect, name the atlas first, atlantoaxial joint, another true diarthrodial joint. The atlanto-occipital joint is classified as an ellipsoid joint. Ellipsoid joint. There's a picture. Again, look at the difference in these spinous processes or transverse processes. How weird they are. Very asymmetrical. This is a PA view of the C1 and C2. We can see the dens really nicely now. And we'll learn next class, we'll learn about the ligaments and the facets. There's a facet for the dens on the posterior part of the, what's this piece called? Anterior arch of atlas. Yep, nice view. There's the lateral mass. This is an older patient because these are very concave right here. There's the superior articular process of the lateral mass. Or I should just say the superior part of the lateral mass. There's the inferior joint right there. If we cut the pedicles and pull that same view, if we cut and pull all this stuff off, just rip it right out of there. And take the spinal cord out so we can see the body. There's the posterior body of C2. We see a very important ligament here. That's the cruciform ligament. And this is the transverse ligament of atlas I was talking about. How important it is for holding, stabilizing C1 and C2. We'll get to that next lecture. But here's the atlanto-occipital joints are here. Atlanto-axial joint is here. In reality, they have a joint capsule and are covered. And there they are, CT coronal cut right through the dens. You can see these joints quite nicely on CT scan. I've lost track of time again. I think we're probably about done. Lateral mass, there's a superior articular process of the lateral mass, inferior articular process. It's forming these joints. There's the occipital condyle. CT is very cool, isn't it? We've talked about the transverse process, haven't we? Where are we at? Where can we stop? Let's stop here. It's getting too hot in here. All right, let's stop right here on the transverse process. See y'all next week.